Please start the meeting.
Good evening, everyone. I'm Dr. Srini Adaklon, Chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons. The Scientific Committee of Kerala Society of Ophthalmic Surgeons have started a new program, Innovations in Surgical Techniques. This is the third module of that. The first one we had on the high volume phaco surgery. And the second one was by Dr. Pradeep Sharma on innovations in squint surgery techniques. And now we are fortunate to have Dr. Amulya Sahu, who is a doyen in the field of cataract surgery and specifically manual sutureless incision cataract surgery. And Sir is a founder chairman of Sahu Eye Hospitals. And he's more importantly, he's a founder chairman of MSICS, which is doing wonderful job in promoting and the MSICS worldwide. And he has been the secretary, president of Bombay Ophthalmic Association, and he has conducted instruction courses on SICS worldwide in ASERs in USA, China, Indonesia, Philippines, Malaysia, Egypt, Thailand, and he's an innovator of 2mm MSICS and is conducted various conferences, World Conference on MSICS, and he is in the chairman board of office bearers, Global Journal of Cataract Surgery and Research in Ophthalmology. He was awarded International Master Gold Medal by Bombay Ophthalmic Association in 2003. And his areas of interest include cataract, glaucoma, cornea, squint, pediatric glaucoma management. And he's a contributing author in international books. One of his publications is Clear Lens Extraction, published in Lens-Based Refractory Surgery, Bilateral Sequential MSICS, same sitting. And he is interested in poetry. One of it is Journey to Nothing. And he sings, he's big time into social work. And welcome, Dr. Amulya Sahu, sir, to the Kerala Society of Ophthalmic Surgeons Scientific Committee, CME. I mean, we are fortunate to have you with us, and over to you, sir.
Thank you, Dr. Srini. It was nice of you to introduce me this way. And I'm fortunate to be with the people like you who are doing extremely nice work and good volume of cataract surgery. And I look forward to Kerala to lead the way and take the leadership of promoting MSICS. So with that, I would like to share a video of ISMSS journey. As you know that we are present in almost 19 countries, including USA and Australia. Now we opened in Abu Dhabi and Singapore. So we are the world leaders in MSICS. So I want all of you to lead from the front. And so far we have been the follower in every surgery or any new innovation. But in SICS, we are the leader, and that is why I started the World Conference, so that afterwards nobody can claim that we are following them. So that was my thinking before starting the World Conference. Now we have done the 4 World Conferences, and now the 5th is going to happen in Hyderabad. So I'm sharing the journey of
Sir.
And by just 1 minute.
Yeah.
1 minute.
Sir, your 2mm MSICS presentation is on. You can. The other one.
We can. If it is not starting, then I will start with these things.
Yeah, we'll start with this. Then after that.
Okay, we can see that.
Yeah.
So, see, as you know that.
Can you please make it full screen, sir?
Yeah. See, India was the leader of 6th century BC, and Sushruta was one of our pioneers in the SICS surgery. Not as we know it, but he had innovated a lot of instruments and other things. And you see that there was a long gap till 17th century. Jacques Daville did the extracapsular, and then the Sark designed the ICCE, and then Harold Ridley brought a qualitative change, and Charles Kelman totally changed the the way we know cataract surgery. But as you know that the advancement has taken not only in the machine designing and other things, which is also the skill advancement has also happened. I do a 2mm incision cataract surgery. Jagannath Brahmani, wound modulation, astigmatic free MSICS. Everybody should now know his algorithm he has developed and follow it. And Ravindran, MS Ravindra, as all you know, that he is totally dedicated to MSICS, though he has been trained as a vitreoretinal surgeon and among the first to do the echo surgery. But he has developed this tunnel floor entry. And then Rajiv Raut, the MSICS, this is a smart incision. He is giving wonderful result with a 6mm SICS. And Anil Shah's snare. Anil Shah is located in a very remote place, village like place. And there he developed this snare, which is one of the, I think the MyLoop is one of the copy of those kind of thinking process. And then anesthesia also, we started with facial blocks and all those things. And now retrobulbar is, we have gone into peribulbar anesthesia to topical to soft tenon and intracameral, and there has been progress in those fronts. And the lenses also, as you all of you know, that lenses there has been, now I'm using a lot of autofocus lenses there with extreme good result. Multifocal and other thing, of course, they are becoming little obsolete at this moment because of the different glare and other complications. So now to share the little bit of the journey of this 2mm designing. So 2005, when I was the president of Bombay Ophthalmic Association, I was feeling all the stage was occupied by phaco people, and they were saying that I do this machine, this machine, that machine, and all those things. And if you see the SICS surgeon, they were hiding their faces. They will not tell that they are doing SICS because those 70% of the people were doing this one form or other SICS, but they were totally demoralized because they were not getting the platform to express themselves. And there was looking down sort of phenomena was there. You are a lesser causian sort of. And in Bombay, so that this happened, and I said that unless we have a separate platform for these people to express themselves, they will not be taken, they will not be given the importance. So that is how the ISMSICS came into being. And then on that same year, I operated in, Naughty's place, Natarajan's place, and I demonstrated a 3mm MSICS there. I said, unless we show that, and there also, Haldipurkar has given few comments which I'm not able to share here. They said that if you go anything lesser than that, the phaco surgeon has to find a different place. So that time he observed that, and I'm taking, now we are going to Vietnam together. So I'll tell him that your prophecy has come true. So now because a lot of designing, the importance of phaco was a small incision. But then I said that if you are a SICS surgeon, as it was done that time, it was a little messy. People were not feeling encouraged to follow this thing because the whole appearance was looking very messy, and the large cut and all sort of things were happening. I said, unless we reduce and the size of the incision and match the echo in their place, nobody will take us seriously. So I went on designing my equipments in a way where we can do a 2 mm surgery without compromising the endothelium. I took the specular microscope just for this purpose, so that if I have to claim that I am doing a good surgery 2 mm, I must have the equipment to prove I am right. So now with this I modified these instruments. As you see, that is a single jet cannula. As you know that all the MSICS surgeons must be having this experience. When they do a surgery, a lot of cortical material gets deposited behind the endothelium. So your visibility becomes crowded and you don't see properly. And whatever cannula was available, that was not removing this and this sort of the cortex. So I did just the same cannula in the front. I give a prick there, and this flow goes and totally washes out. And this is a multiple jet cannula. As you see that it flushes out the debris from the tunnels and the angles and other places, and also it can remove the cortex from the top. But and the force is not that much, so it will not affect the endothelium. Now, in the third is a simple thing, as you know, if you are doing a visco cannula, that if it is a rounded and you are having a side port which is square, if you push that, the Descemet separation will happen. So what I did in that cannula, I just compress it, so it became a square. So in that square, when I was dividing the lens in the anterior chamber, if you are injecting viscous and you have a round thing, there is a possibility of endothelial touch. When I made it a square and went on injecting visco, so I didn't have that fear, and I can break the lens as I'm going to show you. Now this is a marker. Now I'm doing all the surgery on the axis itself, the stiff axis. So I needed this marker to mark my axis, and I give the incision there. And again, this is a modified cannula. See, the cannula, this Simcoe cannula was the wider. For that you have to make a big incision, side port to introduce that. So I have 24 gauge cannula. I made it, and there is a cannula. There is in the opening is there. Earlier cannula you find just a hole there, but here I have tried to design it having a hanging edge in the front, so which can suck the cortex much better than the a pure hole. Now this Vectis is the main thing which is helping me, because it has gone through the Vectis which are available in the market. As you see, there is a bigger Vectis, and some people have that serration is there. But I went on seeing that they are not helping, because when you have a round edge Vectis, if you are going to bring the lens out, then you have to take the support of the endothelium, and thereby you are damaging the endothelium completely, because it is not engaging. In this Vectis, what happened? The size has been, the gauge has been modified, and then the length has been shortened. The side has been also 2 mm or 2.2 mm, say, and then there is a hanging edge in the front, so which engages the divided nucleus and or the nucleus, and so gradually you can glide it out instead of dragging. So these instruments help me to. Now I will get into this. Okay. Topical anesthesia, marking the incision site by Dr. Sahu's marker, conjunctival and tenons incised separated, 2 mm incision, 1.5 mm behind the limbus with a round incision. And there, this 1.5 mm behind, that is a parallel to each other. Once you make it tangential, the size of the incision becomes bigger. So pocketing is done either side, and that is extended to the cornea. Same pocketing is extended to substance of the cornea, and two side ports are taken by MBR spear. I advocate that all of you who are doing side port use MBR thread, because the kind of knife is available, that is the flat knife. So MBR gives you a square incision, but the other thing is very flat. And so if you are putting your blister cannula, it really, there is no space. You have to push it. So 10 and 2 o'clock, two side ports are given. Hydro procedure, as all of you know, I have that. I use the single jet cannula for the hydro procedure, because the jet goes and hits the posterior surface of the capsule instead of going and hitting in the periphery. So gradually it is with mild infusion, so I can separate the lens and so this modified I have dialer, because they are, I just nudge the lens out. Polishing. So you can directly put or you can inject. We use air bubble always. If I'm sending the patient same day, I just use the saline. Otherwise, this is a dividing the lens in the AC. That was dividing the lens in the tunnel. It's a temporal incision. So while doing this incision, please remember that don't touch the any part of the tunnel or try to not to touch the dissected area. Continuously, when you are going and continuously visco is being injected to create a space between the lens and the endothelium. So this is a multifocal lens.
So what you'll be describing the instrument that you use to
Yeah,
divide it, right?
Yeah, this is a see, this is a pre-chopper and designed by some I'm forgetting the name. Blocks.
Sohail
Irfan.
No. Because that was I thought actually I called him to compliment, but then I found out that before that the NATO has shown this chopper of Brostovsky or something. I'm forgetting his name. So I was disappointed because he has not recognized that this man has done this work. Anyway, that is for people to find it out by who is the
this particular instrument that you're using, you use it for division in the bag, or even after prolapsing it into the anterior chamber also you can use it for division.
Then this is divided in the bag.
Yeah, I understand. So if you're prolapsing in the nucleus has got prolapsed into the anterior chamber, would you be able to, because that looks a bit lengthy, would you be able to do the division using this in the anterior chamber also, or this is specifically for division in the back?
Actually, the whole challenge was to whether we can divide the lens in there, and now I'm designing some instrument where we can make it multiple pieces there. And I used it in the anteriorly also we can divide it, but anteriorly then we'll take the risk of touching the endothelium.
Endothelium, yeah, that's it looks
so
bit.
Yeah, so I'm just designing some instrument where we can really fragment the nucleus without kind of electrical power or anything. So that we will, after some days, we will find it out a way. So where this divided two pieces, we can make it multiple pieces. So that then we can flush it out instead of using so much of.
Sir, one difficulty that I'm actually seeing it on my laptop and mobile also. One difficulty that I'm finding with this is that it's a bit not really that one video is not filling the screen, so I'm not able to really see what actual process is happening. I mean, it's because Dr. Kashyap, there's a chat in the box. So good, but clarity is poor. Should have been magnified. So let's see. Like after you finish the presentation, if we can actually show just a video instead of through the PowerPoint, we'll just see, sir. So I'm just replying to them. Okay, sir. Please continue, sir.
Okay. So you want to see this was a hard cataract. This is you see how it can be divided there. Okay, that was divided. There's nothing much to see. Now these are my studies where there is nothing much. Whether we should discuss and share each other's experience. I have found that astigmatism we have reduced quite a bit of hardly any I'm not contributing to astigmatism, but our study. There's the next day I have taken the photograph. You see the cornea, and the endothelium loss is also not significant. So astigmatism slide up to 0.75, it can be reduced with 2 millimeter also. So,
sir, there is another query on the YouTube chat box. What is the size of the by Dr. Ronak Solanki? Is asking what is the size of the internal entry?
It is well, that point has been raised that it is 7 millimeter around inside inner opening, no?
Inner opening. That's probably the what he's asking. He's asking what is the size of the internal entry.
In internal opening around 7 millimeter it is coming. Okay. But I'm thinking that now that the question has been raised, can we do it in the same external internal? We can keep it. And that is where I'm going to focus, because it was a matter of habit, and we mostly knew that internal opening is not contributing much to the astigmatism part. So we were just in a comfort zone. But now that it has been raised, so I'm focusing that whether we can keep the internal and external incision same, so that so this is a maybe it needs more study to see whether what is happening.
See,
But-
what I have, can I say what I have found is that it is not internal opening per se, but it's a sliding of the internal opening. If it slides, the corneal curvature changes. So
come again, I couldn't get it. What is that?
the sliding of the internal opening.
Can you please explain what you mean by sliding, sir?
Sliding is the anterior lamellae is there, the posterior lamellae is there, right?
Mhm.
Yeah.
Follow what I mean? See,
Yeah.
when you make a tunnel, you have the anterior part and the posterior lamellae.
Mhm.
Okay. And if the anterior lamellae and posterior lamellae should be like this together at the end of the surgery. But if it becomes like this or like this, that's what I mean by sliding.
Yeah, I understand, sir. But I mean,
So when horizontal
does it really happen that
no,
see, mostly like you find it both opposed at wherever you've entered. Does the sliding? I mean, at least in the temporal section, I've not seen that this sliding happen. But I'm not sure about the superior section.
No,
Definitely some.
it happens if it is a superior section and if the horizontal length is big. If the horizontal length is 2 millimeter or 3 millimeter, then the sliding doesn't happen because that protects. But supposing the horizontal length is big, like 6 mil or 7 millimeters or 8 millimeters, that is the usual SICS. Then the astigmatism is a lot, maybe 2 diopter, 3 diopter astigmatism you will get. But Dr. Sahu's technique, since the horizontal length is much less, 2 millimeter only, although there is back cuts, that the fact that it is very small, it prevents the sliding. So that prevents astigmatism. So that's what I found. But I found that when we do temporal incision, temporal section, even if the horizontal incision is the horizontal incision, the external incision is big, even up to 7 or 8 millimeters, there is hardly any astigmatism, there's hardly any sliding. If it is temporal, that's what I have found. So that is why I used to do this 2 to 3 millimeter incision about 10, 15 years ago. And then I found when I shifted to temporal incision and made the incision big, external incision, I found that there is hardly any surgically induced astigmatism. So I shifted to temporal incision and I get it astigmatism nil. This is my hands and my experience.
Yeah, your temporal incision do not contribute that much to the astigmatism because the visual axis, it is far away from the visual axis, and the fiber arrangements are the straight incision. It is advised temporally straight incision is better because of the fiber configuration. But really, I saw your videos and they are good. And please focus on this temporal incision and come out with a lot of papers. Do some research because you are doing excellent surgery. And always I am telling you, all of you, I hold with a lot of respect, that you must write papers and do some research work. And
Yeah, we are working on it.
every step has to be, every step has to be explained scientifically, and we must. The world should not find any defect in our, surgery or anything.
Sure. The other difference I do is I don't make a conjunctival flap. I make a transconjunctival incision. So immediately the bleeding is there, but the bleeding is there and the blood clot is there. So it looks a little messy. But then day one, you find that there is hardly any, that those bleedings and everything is irrelevant. Only thing you have to tell the patient that there'll be a little bit of redness, don't worry. But the ultimate results are very good. So with this transconjunctival incision, because when we make an incision, a mini flap is formed. That is a limbus-based flap, not a phonics-based. And that flap covers the wound and it promotes healing, faster healing, I feel.
See, if that, I have seen few people doing that, and in the camp also most of the time they are doing this way. But if you are doing it temporarily, the conjunctiva is not that loose. But if you are doing at 12 o'clock, the conjunctival is loose and the incision is not that defined. So there also we need more focusing, and more people should do it and come out with their result. I've tried once or twice at 12 o'clock. It was not satisfying. So I
Sir,
have to-
see, may I make a comment? Like, see, when I was doing, as I said before the session started, after Epicenter, I went to Shankara Coimbatore, where we that was the time when temporal SICS was getting popularized. Basically, started from Shankara, and we were doing lakhs. And in between, like, I thought, what Dr. Philip Kurula said. Will go transconjunctival and look neat, and the amount of foreign body sensation will be lesser. As Sahu sir said, we should publish only then people would really agree to it. But from our side, we found if you take the overall the end of rate, see, there were we did thousands. One or two cases had endophthalmitis. See, one postulation is that it's not properly covering the wound. This conjunctiva. See, it looks nice, it looks neat and all. You see, when it is phonics based and you are putting it over the wound, the external entry, then it's covered totally. When it is transconjunctival, see, there is definite possibilities. You can really think about it. Going transconjunctivally, that external opening might not get covered if there is some retraction or whatever. Get covered, and you're going for a temporal. You're going for a 6-7 millimeter section. I personally feel that it's not really safe. It would be really good in some expert like Philip Purwala sir's hands, but I'm not sure if that is something that can be recommended for everyone. For an SICS, anyway, you're opening the conjunctiva, it is you have a conjunctival covering over the external. That's going to make it absolutely safe. I mean, that section is even safer than to 2.2 millimeter clear corneal phaco section, because the wound is totally covered. So transconjunctival, I have my reservations on it. Sir, Sahu sir, your opinion on transconjunctival?
The transconjunctival we almost try and have a volume, create a volume of surgery to give an opinion, because we cannot cannot give an opinion unless we have at least. I will like to do hundreds of surgery, and all of you who have doing so much of surgery must take up this thing, and let us have published paper, your study, my study, and multi-centric study on transconjunctival. Let us form a group. Let us form a group. WhatsApp group.
Srini, can I make a point, Srini?
Yeah, please.
Around 20 years back. Minumathan. Yeah. So 20 years back in Aravind, we were converted completely onto temporal and doing very high volume temporal. So we would train people and start doing superiorly so that people get very good at making very good sclerocorneal tunnels, and then shift temporal. Yeah. Because the arrangement of fibers, the length, the size of the limbus, all those were different temporally. The bleeders were different, and that made making the tunnel more difficult. And it had to be a very good tunnel temporally because it is an open interpalpebral space. So it was being done by all levels of surgeons, trainees, postgraduates, seniors, and all. So it had to come very, very slowly. It had to convert from superior to temporal, because as you said, the covering part is very, very crucial. It has to be cauterized and it should not retract. And the internal incision has to be very good and long. If you see Dr. M.S. Ravindra's cases, the corneal part of it is very, very big. It is almost 2 millimeters into the clear cornea. Then only it closes well. So when we are making large straight cuts or frowns or with little back cuts, and when we do very large nuclei, we need to have larger internal incisions and external incisions. So they have to be very meticulously done, and then only they close. And the bleeding part also is a little more than the superior incisions. So when it had to be streamlined across different levels of expertise, we had, I think, nowadays in Aravind, also in Free Hospital, I think juniors are made to do superior incisions and then only slowly graduate on to temporal incisions, and with a good conjunctival, completely covered conjunctiva. And if there is retraction, it is definitely cauterized, and sometimes it's generally you see very old people, very hard cataracts, very thin conjunctiva, very less tenons. They tend to tear and they don't appose properly. So if it is not apposing very well, we encourage to put even a suture at the end of the surgery to completely cover the incision temporarily, so that you don't get leaks, shallow chambers, bleeds, or even endophthalmitis. But astigmatism wise, definitely, as sir said, this is highly neutral, and even the people, more than 85% of people have against the rule astigmatism. And this, even if it induces a little bit, it is going to negate what was originally there. So that is the advantage, but superior will add on to that. So that is how, as Dr. Philip was telling, the back cuts will stabilize the incision and make the opening actually larger than 2 millimeters or 3 millimeter horizontal cut, so that it can easily take out the divided nucleus or even the smaller, softer nucleus in toto. And it is not basically the 2 millimeter or 3 millimeter making the whole tunnel, because the internal is bigger. The outer also is bigger by the back cuts. But the back cuts and the small horizontal makes it much more stable and closes well and avoids the sliding and the astigmatism and closure part, especially superiorly. Thank you.
Well said.
Dr. Naveen Gopal, any?
Sir, this is Dr. Naveen from Bangalore. I am a pure phaco surgeon, sir. I am a little bit odd ball in this group, sorry. But I loved doing SICS when I used to do it. I simply loved it. But as a private practitioner in a metro city in Bangalore, one point I would like to make is, even if there is a small subconjunctival hemorrhage anywhere in the conjunctiva, even if I give 6/6 N6 in a pan-optics patient will grip throughout their life. Whatever small problem they have any time in the future, they will blame it on that small subconjunctival hemorrhage that I would have made just holding the conjunctiva. In such cases, what I'm trying to say is, I might be wrong. Your surgery was beautiful, absolutely no doubt about it. But from the practical standpoint of view, whatever SICS incision that you're doing, even if it's 2 millimeter, 2.2 millimeter, I don't think it competes with the phaco that what we are doing now, which is the latest techniques in the world, which is world accepted. That is my small, humble point of view that I would like to make, sir. Any comments is welcome, sir. Sorry if I was.
I'll tell you. We are not, the SICS is not here to compete with phaco. It has come to stay on its own, and the result speaks for itself. So I've been the early phaco surgeons in Bombay. So in my hospitals, we are doing day in and day out phaco surgery, and SICS here to stay because it delivers the good. And the problem with our surgeons is that they have given more importance to technology rather than to themselves. And nobody comes and asks me, do this or that. Nobody. And a few days before, I did a high-end operation and there was a lot of bleeding. So second day I clear it, and now this patient came for the next eye operations. So such things happen in any surgeon's hand, but if you are confident and you know you are marketing yourself, no patient asks anything. The problem is that we have forgotten promoting surgeon. We have gone for the machine. So surgeon
True, sir.
factor is very important. Whenever
True, sir.
you say, I will do whatever I want to do, patient will always be comfortable.
Very
But
true, sir.
then-
You're much more experienced than me. I bow my head to you. But my small doubt is, even that's external back cut what you give and the internal 7 millimeters incision, according to whatever little experience what I have, induces at least -1 to -1.5 astigmatism down the lane, which progresses over period of time. That is my small experience what I have, sir. What is your opinion on that?
Me, I have done thousands of operations and my study is very meticulous because when I'm going to talk to the international audience, so my data should be really foolproof. My staffs are engaged in this finding faults, anything is there. So one of my, recently they said that after 6 months or so, you are finding 6 and 6 even in the simple thing, but then I cannot validate it unless I really look into it. They saw the data, but I have to see this. So I want a lot of people should do research and come out with more data. I can only back it with my experience that all of you senior surgeons, please become complete cataract surgeons, not the phaco or SICS surgeons. So,
Sir, one more small doubt I had. When you are taking out smaller pieces through the tunnel, I saw the pieces touching the endothelium and the wound, which is a small lip. Doesn't that affect the wound architecture? And it has to touch the endothelium. What I saw the endothelial count, what you showed, it was 1,500 and 1,800. It's a very good endothelium count. Will this technique hold good in a low endothelial count for say 1,000 and below 1,000? Are you confident of doing with the same technique? What
then
you're
you have
doing
to
now?
go for it. Then you have to go for a bigger incision. So
That's
so
what
you-
I wanted to ask you, sir. Correct, sir. Yes.
You cannot be dogmatic on every
Yes, sir.
2 millimeter.
Correct.
Just an innovation. It is not
Correct.
the panacea for everything.
Correct.
It is those who are masters, those who have done thousands of operations. They want to enjoy themselves. They can move into smaller incision, but for learners, standard 6 millimeter is necessary because they have to
Yes.
master.
Correct.
So, and we have a choice, the thing is that, as Philip says, talked about temporal. Suppose we don't want to create astigmatism, we can move into temporal, which is our prerogative. So big incision, small incision, that don't, it's not a watertight compartment.
Correct.
We
True,
decide
sir.
according to the cat. But Naveen, now that
Sir,
you are
Yes,
taking
if I may,
now
Minu, you have something
Yeah.
to tell?
Yeah, because I just wanted to emphasize on what Sahu sir said in the beginning of this discussion. We are not comparing phaco 2 by 2 millimeter incision and this incision, or phaco as a surgery and SICS as a surgery. Because it is, see, phaco probe, if you want to put in, you cannot make a larger or a smaller incision and put in a probe. So it's a fixed incision which is there. So it is not a comparison between these two. The incisions which are made are titrated to the kind of nucleus which you are dealing with and the technique which you are doing. And later on, after we do many, we will realize that the incisions which we make at particular locations in your hands will induce very minimal astigmatism, especially temporally. And touching endothelium, no question of touching endothelium with any of the nucleus bits, because that is not the idea of doing in any SICS. It will not touch. The technique is right, it will not touch. So that is a different issue. Dividing is a very highly technical thing to do, which takes a lot of practice and experience. So till then, we need to have larger incision, especially when we are doing very hard cataracts. Because I do SICS nowadays when we go into very bad corneas, very bad astigmatisms, very bad black nuclei. So I want cornea, clear cornea. So that is the point. So hemorrhage part, subconjunctival hemorrhage and all those, these are all easily explainable to patients, and previously if told, well, they will accept and all those. That's not a big deal. But as the incision part, definitely the size is not just 2 millimeters, that we all agree that the horizontal cut is what is 2 or 3 millimeters, but it gives space for adequate space for even divided or undivided soft nuclei to come out through. That is why the back cuts are made and the side pockets are made and the internal incision is bigger. So that makes it come out, because you saw the 6 millimeter foldable lens going without folding. So it is like this back cut jaws of this crocodile or python or whatever. It opens up and accommodates this nucleus, and it doesn't touch the endothelium. It is pressed down and brought into the incision and then taken out. So it is a very beautiful procedure to do, and that procedure done well gives excellent results, and it is acknowledged by world over surgeons, phaco surgeons, including Dr. David Chang, who made his Binghorst lecture on SICS in ASCRS when he got the Binghorst medal. He was talking only about SICS being done by Indians and in Nepal and China and also. So it is all accepted and approved by the phaco masters globally. But the thing is that we need to titrate it to the kind of patients, type of cataract, and our own technique, like Dr. Philip was telling, our own technique which will suit to the different types of lenses which we cataracts which we deal with. Thank you.
Thank you, Manu. I totally agree with you. It's not a comparison between SICS and phaco, and it's not, see, 2 millimeter in SICS is not same as 2.2 or whatever in phaco. And as you said, the subconjunctival hemorrhage, you find it on table, you tell the patient, yeah, there's some amount of bleeding, somehow your this thing is there, some bleeding will be there tomorrow, and they usually accept it, at least in my area. And see, SICS for me, and probably for Minu and others who we do see, 40 to 50 surgeries if I do in a day, so 1 or 2 cases invariably is a non-phaco technique, because see, you have a black cataract, poor endothelium and all. I see this is a technique that really saves me in these cases. And for me, it is a temporal SICS. I go for a bigger wound. I still now have not practiced transection or division in the AC or in the back. That requires a lot of training. It's really wonderful hands, and see, only when it can actually be practiced by everyone, then yes. So for that, probably sir and others who are actually doing it should actually have training programs to train people into it. But for me, I love my phaco, and that's what is giving me the best results. But SICS is something that is actually really going to help me in very difficult cases like black cataract. And sir, see, can we? There are a lot of queries on the technique as such on the YouTube. Sir, do you have just separate videos as such? Amulya, Sahu, sir.
Yeah.
So I think you can unshare now, and we can go to videos which will be there in the whole screen, because it was 2 videos, and in these laptops and all, people are not able to actually really see the technique. Even I couldn't really understand exactly the process of division and all. It's beautiful from whatever I could see, but if I want to practice it, I need to see exactly what sir is doing. So there are a lot of queries, like Dr. Subhash Jana asked, what is the tunnel size? Sir, can you unshare and go to a video from your gallery, sir?
Yeah.
So I'll just go through.
This is the journal. Let me just finish it with this.
Yeah.
Journal, this is the SICS issue. All of you should have. It is one of the wonderful issue SICS IGO has published. And our world conference is coming, so take note of it. And November 17 to 19 in Hyderabad. So any of you who are interested, you can join it. And thank you, and play the video.
Sir, thank you. You unshare it and go to the video, sir. And so while you're sharing the video, I'll just share the questions that are there on the YouTube. Dr. Govind from Nepal is asking, so can we try to perform this 2 millimeters SICS in all types of cataract? Then Dr. Newman Paul is asking, what is the contraindication of 2 mm MSICS? Dr. Sudama Basuki is asking, how can we get the instruments for dividing the nucleus, and what is the name of the instrument? Dr. Subhashish Jana is asking, what is the reason behind giving large peritomy for 2 mm SICS? How much? Dr. Sudharma Patra is asking how much? What is the length of the side cuts and all? So these are the questions. So can we see a few of your videos, pure videos as such?
Yeah, I'm saying.
Can I make a comment?
Sir, please.
Just a comment as he's getting ready about this conjunctival covering of the wound. What I do is, when I'm not suggesting it for beginners. Transconjunctival incision, what I do is I just wrinkle the conjunctiva towards the limbus and do like that, so that there is a wrinkling of the conjunctiva, and then cut. So when the cut is over, the conjunctiva falls back, the whole of the incision is covered. I don't know whether I communicated it well, but
Got it.
Yeah, that's pulling the conjunctiva towards the limbus.
Yeah.
Right.
Before cutting.
The conjunctival is not cut. The conjunctival cut is not more than 4 to 5 millimeter, because there is no need to damage the conjunctiva. And say ballpoint country I'm not using, I'm erasing. It is not cauterizing, it is erasing the superficial vessels.
Sir, are there back cuts in this incision now, sir? In this case,
1.5 millimeter.
are there back cuts?
There are back cuts. Without back cut,
there are back cuts.
If you are not giving a back cut, then you will have a pulse string effect, and there will be endothelial trauma. Because without back cut, there will be a pulse string effect.
So as the video is progressing, like see, through this incision, and you use a Simcoe cannula for aspirating the cortex, right, sir?
Yeah.
So is it really difficult to get the subincisional cortex, or you have any modification in your?
No, because I am taking 2 side ports. So that problem I do not face.
So you aspirate through the side ports, right?
Yeah.
Can I make a comment, please?
And how big is the side port as such? Oh, okay. Just please go through the. Okay. So this is.
So the pointed hand should be towards you to engage it. Otherwise, it will break again. And so with this, we can easily take it out.
Can I make a comment, please?
Yeah.
I have done a few of these surgeries after watching Dr. Sahu do it. I didn't have the guts to try 2 millimeter. I did 3 millimeter because I don't have any special instruments for it. And it works pretty well in the soft cataracts. With the back cuts, without too much of extension, I struggle to put in PMMA lenses. It's next to impossible to put in a 5.5 millimeter optic without an extension on the back cuts. If the back cuts are absolutely straight, I don't see how a 5.5 millimeter optic can go in. You can put in a foldable lens, But 5.5 optic without the back cuts
Um,
being slightly
right.
angulated, it is very difficult. And that's where I think, as Sir said, as the technique gets better and we are able to do it with a smaller internal lip, maybe with foldable lenses, we
Then
should
the
reach a
PMMA
stage where we should not be operating on any axis, because it will become so astigmatic neutral that you can do it on any axis you want without switching the position according to the steep axis.
You see, Nilutpanna Deuri, she learned the 2 millimeter, and she has been regularly putting PMMA lens in this 2 millimeter with a 2 millimeter back cut.
Nilupatna, she's very capable. She's a very excellent ophthalmologist. And
No, Ross, Srini, see, actually, when we have to consider an L-shaped incision has been described, and it is published that if you make a 3 millimeter horizontal and a 3 millimeter or a 2.5 millimeter back cut, it will end up with the 5.5 other side, the third side, through which you can introduce a 5.5 or slightly with a little extension as
No, see,
6 millimeter rigid also will go through that. So we are making two back cuts. Yeah.
Blumenthal advocated a tangential incision with this thing. That makes the wound size very big. But with the parallel incisions, the wound size, the external wound size remains limited. So with that also you can put a PMMA lens because of the pocket available.
So
whatever pocket on the side, there has to be an outer area through which this PMMA or the rigid one has to go. So it will go. That is the structure of this kind of a back cut when you make an L, or now it becomes like a two back cuts and this one. So that is enough to take it in. If you structurally try to draw the diagram and see the third axis along with the two back cuts and the horizontal 3 millimeters.
If the incision is 2 millimeters in size with a back cut of 2 millimeters, then the angle will be about 3.3
that may
millimeters.
That may be difficult.
Millimeters.
Yes, that may be difficult. That is difficult.
Yeah,
3,
so
it has to be 3 and around 2.5 and on both sides and little angulated. That's what I have realized. Or it is 3 into 3. If it has to be 3 and a back cut.
In the beginning, what happens is people don't make the back cuts long enough, and the importance of a long back cut is underestimated here. We think we can easily manage, but you cannot put in a non-foldable lens without making adequate back cuts.
And back cut is not going to affect the astigmatism at all. So, I mean, you don't have to restrict your the length of your back cuts, but 2 millimeter and back cuts, Minu, what do you think? Like 2 millimeter and 3 millimeter, 2 millimeter back cuts?
For 6 millimeter optic, it is difficult.
It is difficult. Yeah.
Can I show my video also on?
Ankit, can you please share?
Jacob, actually, if you have seen some videos, some people show in a 2.8 through a 2.8 itself, people drag out foldables. So foldables can go very easily, even if it is 2 and 2. So, absolutely. But rigids will be tough.
Yeah, so I did a few surgeries after seeing this wonderful surgery by Dr. Sahu. I was inspired to do, and I tried a few, sir. And I did them, and it was successful. But the problem was I could not put PMMA lenses. I had to put foldable lenses. In fact, one I had tried PMMA, I finally extended the wound.
Those of you who are
also
interested,
known as tiny.
You can have a wet lab, and we can do a slide. I will come there, and any of you, and do the surgery. So you pick up this 2 millimeter. I find quite intelligent and bright people. They should.
Yeah, we'll plan, sir. We'll plan something, sir.
Yeah. So because I feel that you people can sign in the world stage, because now I've been invited to Moscow to do surgery there. So, but I cannot go everywhere. So get ready. The world
Yeah,
is
Minu was telling the story of him going to present in China somewhere, and
Yeah, we had an instruction course on SICS. And there was
Yeah.
one Chinese doctor who got up and said he was a phaco surgeon and now he is doing SICS only. He has converted back to SICS because that is giving equally good results and the other people around him are doing it at lesser cost. And so he had to convert from phaco to SICS. So that was an interesting comment which I got from China once we did an APO instruction course on SICS.
So this time we are asking for a instruction course. You why not take the lead? We
Oh,
can
sure,
have
sir. Sure. Yeah.
So we'll be in touch.
Sure.
Because Abha Hussain is coming to Hyderabad. I told her that we want a ISMSIS instruction course.
Ankit, please play the
Incision
video.
cataract surgery. This is done under topical anesthesia. A 2 mm incision is made at the limbus and back cuts given. Back cuts are minimally diverging so that effectively it is about 3 mm. Scleral pock and sclerocorneal tunnel is made. Anterior chamber entry is done using keratome and it is extended sideways so that internal incision is about 7 mm to 8 mm. Visco injection is done. Capsulorhexis is better done under a dye, but in this case, dye was not used because the glow was good. Capsulorhexis is completed and a cruciate incision is made over the cortex. Under the AC maintainer, hydrodissection is done. A part of the nucleus comes into the anterior chamber. The rest of the nucleus is rotated into the anterior chamber. Nucleus delivery is done with a hook and a serrated vectis using the sandwich technique. The serrated vectis used here is designed by Dr. Philip Kuruvilla. It is serrated and narrow and not as big as the usual vectis. The cortical wash is done with just an ordinary cannula. AC maintainer is there, so it keeps the anterior chamber deep and prevents the anterior chamber from collapsing. Intraocular lens is loaded the usual way. And it is injected into the bag. Dr. Philip Kuruvilla does not usually use visco before intraocular lens implantation, but sometimes he does. One advantage of not using visco is you don't have to wash it off. You can do minimal washing after intraocular lens insertion. Stromal hydration is done, and as you can see, the case was done under topical anesthesia. Thank you.
Excellent surgery. And one thing is that the chamber maintainer, AC maintainer, I think all of us has to start using it. It has got a big role to play. And Philip, excellent surgery. But limbus, did you study the astigmatism happening? You are close to so much up to the limbus. So what is the astigmatic outcome? I think you should study that.
Yeah.
And you are using two instruments to bring the lens out. The chamber should remain maintained. Maybe you are using AC maintainer. Otherwise, there is a chance of touching the endothelium. Because continuously, if you are without AC maintainer, sometimes the chamber collapses. And inadvertently, in your hand, it may not happen, but in other places, they may touch the endothelium. So anyway, there are different varieties. And in your method also, Philip, you were to write papers now. And
no, but that would work only in such a soft nucleus, right, sir? Philip Kurol, sir, have you tried this technique in a grade 4 nucleus? It won't really cut, right?
Hard cataracts, it doesn't work.
It doesn't work.
But, even up to 3 and all that, it used to work. But see, the other point is, see, now for the sandwich technique, I don't use a hook. I use a 26 gauge needle, a Rex's cannula, and connected to a viscomet. And then we keep injecting, as I think Dr. Sahu showed. Inject the visco at the same time as we take it out, so that endothelial touch is not there. So the first day itself, the cornea is clear. But as I said, surgery was done in 2011. Before that, around that time, I used to do it regularly. But later, in one of the KSOS conferences, it was in Trivandrum many years ago. And I think it was Dr. Jason who said that in the temporal section is better. So I started temporal, and then to my surprise, I found that even if the external incision is 7 millimeters, 8 millimeters, it doesn't cause astigmatism. Only thing is the tunnel has to be long. Then I said, why struggle with the superior incision 3 millimeters? So I have actually switched over totally to temporal incision, a larger incision, but no surgically induced astigmatism. But this
even if you try to neutralize,
yeah, you can't.
This thing, it doesn't get neutralized when you go for a temporal. This thing, you feel okay against the rule astigmatism. I'll go for a temporal, so it can be larger. It doesn't. It's so astigmatically neutral. 6 millimeter, 7 millimeter temporal MSICS. It's good. Like the only issue is that you are telling that it's a 7 millimeter section. Otherwise, it's a wonderful technique, temporal MSICS.
Yeah, the other thing is, no, I do use this 3 millimeter superior incision when there is a combined surgery of vitreoretinal surgery. So vitreosurgeon Dr. Ashok tells me, please don't touch the temporal side. I will have to put the port there. So I do a superior incision, 3 millimeter incision, and put sutures also. And then he takes over after the cataract surgery is over. So that is the only time when I do. But this I said it just, showed it just for interest sake.
This was 12 years back. Even now, sir's hands are as steady as that time. He's got wonderful hands.
Can I ask a question for
Dr.
Sahu or Dr. Minu? The same 2 millimeter incision, if you're doing it superiorly, and instead of making like a straight incision with a back cut, if you do the same incision as a U, it will give you every advantage of 2 millimeter incision. It will cut down the sliding of the internal lip, and it might even reduce the astigmatism if it is creating a little bit of astigmatism. So instead of making a straight line with a back cut, why can't we do it as an inverted U, the same size incision?
See, this back, I do a round incision and back cut that makes 2 wounds, not 1 wound. So with a 2 wound, when the force is gets transmitted to the periphery, not to the endothelium. And if you are doing only 1 wound, as you are saying, the U-cut and other thing, it will give you a bursting effect. When you are dragging the nucleus out, the force will go to the endothelium, not to the periphery. So the 2 wound construction is advantageous for not affecting the endothelium. So that's why it's not a 1 wound uniform wound. It is a 2 wounds. First is a thing, and there is a joint between the 2. So that is the advantage.
Yeah,
so you don't advise.
I'm sorry, Srini, continue.
No, continue.
Yeah, thing is, I have not done this, and so I can't comment on if you change the shape, what happens. But then, the previous question which you asked about the rigid 6 millimeter. See, if you make the internal incision, as you just saw in Philip's video, if the internal incision is 7 millimeters, that means it is around 2 more millimeters to the side of our cut, scleral cut, 2 to 3 millimeters on that side. So the horizontal of this triangle will be one end is in the cornea on 3 millimeters on the other side, and the 2 millimeter back cut on this side. So that will be the third side of the triangle. So that will let in the 6 millimeter optic through that. So that is how with the larger internal incision you can get 6 millimeter lenses inside.
But the whole purpose of advances in cataract surgery is to, because all the newer developments in intraocular lenses are coming in foldable platforms. So it's PMMA lenses are not being used that frequently. So I'm not sure if that really matters, because everything, all developments, all technological advances are happening in a foldable platform. PMMA lenses done 30 years back, 40 years back, they're all very good, probably even better than the latest. But everything, see, the multifocality, EDOF, everything is coming in foldable. So we one Minu, I'm not sure if for me the difficulty for me with a 7 millimeter or 6 millimeter temporal MSICS is injecting the intraocular lens with an injector, because it's a bigger wound, and the chamber doesn't stay as, because it just opens up. But we do it. The advantage with this 2 millimeter with back cuts is that it's injecting a foldable intraocular lens will be very easy. It'll be.
So what I do is, if you have a 6 millimeter itself, I inject IOL only under sodium hyaluronate in the bag, and it is brought almost very close to the tip before I enter into the chamber, and it is injected quite fast. So once I inject, there will be some shallowing, little bit. But if it is sodium hyaluronate, and you bring the lens to the tip of the injector just before you go in, and then if you inject, it goes in 1 or 2 seconds, and it doesn't shallow much. And after injecting, I again put in viscoelastic so that it deepens before I dilate into the bag. I don't let it go into the bag.
I even try to close the wound with the second instrument while I inject with my right hand. So these are techniques that we modify. But for Dr. Sahu's technique, I think putting a foldable intraocular lens is as easy as doing it in a clay corneal or posterior limbal phaco. So that is one huge advantage I'm seeing with that 2 millimeter SICS. It's not actually like overall, if you take, it might be more, because internal lip is 7 millimeter. But this is a huge advantage that I see with this technique. Sir, Sahu sir, your comment on the intraocular lenses in MSICS?
We are doing all kind of lenses. There is excellent results. Now the autofocus lens, I don't know how many of you have used it. The autofocus lens is absolutely wonderful.
So is it that Dr. Kakadia's lens, or is it Dr. Kakadia's?
Kakadia's. Excellent results. So, and the cost effective, besides, you can charge quite a good, make it a premium surgery. Charge patients are not hesitant to pay, because you are giving good results, which I am seeing 6.6 N6 and the free of glasses and other thing. So there's an Indian lens, and very well designed, and a lot of cases. We are almost thousands of cases I must have done. So
how much does the lens cost, sir?
Progressive design?
I think it should be around 10,000, around some within that range. Maybe, I don't know.
What is the lens?
My case, I'm getting around 9,000 something.
What is the name of the lens?
Which company is marketing it, sir?
Marketing, though, you talk to this Kakade directly, because they have not used anybody, because they don't want to promote in a big way.
Sir, is it not the progressive lens design like the progressive glasses? Is it not the same thing? That one is it not?
That is
Yeah.
that
Okay.
is, yeah. But if the result is good, people are very comfortable and driving and other thing, no problems. Cost effective and take home will be more. So you can go for it. So
Sir,
it is,
one question about that lens. That is a hydrophilic lens, right, sir?
no,
That's a,
they have
is that a
they are coming they are coming with a hydrophobic also. That is
that's what, because what couple of lenses what that sent for me to try it out. What are the hydrophilic lens? In hydrophilic lens, what happens is it keeps on moving. It doesn't get attached to the posterior capsule, and
no,
thing will
they
be
have
more.
increased the size you have not seen. Size and
30
design.
millimeters.
The size and design and the haptics, serrations and
Serration.
everything. Serrations are there in the haptics and very flexible haptics. So easy to put. And they've given two holes, so which will keep you in a 12 o'clock position properly. So
Can you please explain the method of how it acts in briefly, sir? I didn't understand that much.
Which one?
The principle of that progressive lens, because the
Yes.
lens doesn't move. Your axis of your pupil and pupillary axis and the visual axis doesn't move. Then how would you expect the pupillary, the visual axis to come down if it is not, if it is paracentral?
See, I may not be,
That part I didn't understand.
I may not be able to give you the clear cut
I-
technical thing. But what I'm seeing with the patient, I'm taking patient's impression. The patients are coming with one eye and next eye they follow. Then as a surgeon, you understand. If they are not happy, they will not come for next time. So they usually come, and I have seen the result this way. Now, once a scientific evaluation, another thing, maybe I have to wait a little more time and focus on that. But Ramesh Saha can give you all details. If you are in touch with him, you can ask him. And they are coming to this conference also. They will explain it there. So technical things, because they are involved in this innovations and other things. I'm a user, so.
But their C3R machine I recently used, it is fantastic. I must say,
Which
it is a
one?
fantastic
Which
innovation.
one?
The C3R machine which gets attached to the microscope, fantastic innovation. That hands
you
down.
use all of you use one or two lenses, and then you will come to realize it, because it's a wonderful lens.
Thank you, sir. Like it's been almost 1.5 hours, and I didn't know that I was planning for a 1 hour session. So wonderful discussion, sir, and thanks a lot for sparing your valuable time with us. And it's I mean, you're doing a great job with ISM MSICS, and you're propagating MSICS world over, and we love you, sir, for that. And great, sir.
I'll be more enriched if you all people join in this journey, because people like talented people like you, the world needs you.
Yes,
And platform is yours. So come and with papers, publications, give some time for research. And Srini, we please keep 1/3 for your SICS surgery. I'm enjoying PECO, you enjoy also SICS, and tomorrow people say that those PECO surgeons, the America, if you are going to talk to them, you say that my volume of PECO is this and SICS I'm doing, they will automatically believe you more than only SICS surgeons. Say, this is a master.
Yeah, you become lazy after some time, sir. Like you're comfortable with one PECO. Yeah, it just it's at the spinal level it goes.
You don't remain service providers. That is my only say. Somebody else can do your job. Then the routine jobs you can pass on to somebody and get into research.
Yes, sir. Yes, sir. Thanks a lot, sir. Thanks a lot, sir.
Because the next generation must see that what you are giving now.
And one more major advantage is we can save lakhs of rupees, sir. CMCs, AMCs, 30 lakhs. That is one thing which
your
first thing
peaceful mind,
is
you go home, sleep peacefully, and a lot of money in your bank, that will not make you unhappy. And you the premium surgery, na, you say that, bhai, terko acha site chahiye na, you pay this much. And now my friend, this Raut is charging 3 lakhs for SICS. So it's not a question of your machine. 3 lakhs. He was telling, when I made 2 lakhs, I thought I have to, how many people will come? But with the 2 lakhs, the booking is so much. He has made it 3 lakhs now. Because people have tons of money. Then they are not seeing your, they want good results. That's all.
True, sir. True.
Because we are selling it as a cheap surgery, so they believe it is cheap. You say it is a
true.
premium surgery, they will pay for it. Because it is they are paying
100% true.
to the surgeon. Your confidence matters. This is a premium surgery, I will charge you this much, they will not ask. They will not ask. You say that I am doing 2 millimeter SICS, my charge is 2 lakhs. The people they've got what they are going to spend. If you go to the heart operation, do you see the money? No. You pay 6 lakhs, 6 lakhs, 7 lakhs, 7 lakhs. So why not my premium surgery is 2 lakhs? Why not 3 lakhs? It is your value, not the surgery. Your confidence and your these things. So I really enjoyed talking all of you, and we will
Thank you,
have
sir.
2 millimeter, at least few of you should get into 2 millimeter. I will come down there so that next time I want more papers.
You have
Sure, sure.
inspired me, sir.
Thanks a
Thank
lot.
you, sir. Thank you.
I enjoyed.
Thank you, Naveen.
Thank you.
Rajesh, you're not spoken, but you're there. He's one of the prolific SICS surgeons in Kerala, and Minu. You all know Minu, and I'll end by saying, like, see, me, Minu, Matthew, we are all high volume phaco surgeons in Kerala, but the most successful cataract surgeon in Kerala is Dr. Shashi Kumar from Palgad. He does SICS only, and he must probably be the richest cataract surgeon, I mean, ophthalmologist in Kerala. So the SICS is great, and it's giving wonderful results, and it's been a wonderful program, and thanks once again, Dr. Amulya, Sahu sir, and we'll end this session now, 1.5 hours. It's been great, sir. Thank you.
Thank you all of you. Thank you all.
Thank you very much.
Thank you. Thank you.
Thank you.